Even though you're on mute, make yours quieter. Okay, is that better? Okay.
Okay.
So welcome. We're thrilled to be here again with Glenn Grossman. Glenn, thank you for hosting this weekly event. I know many of us look forward to it. So many questions, so many answers, and then so many more questions. So Glenn Grossman, our host, is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs in the United States and outside of the United States. Glenn is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So, if you can see on your screen, Glenn has asked, he's put up a poll, a quick anonymous poll. All 50 United States have now loosened their COVID-19 lockdown restrictions to some extent. Without Googling the answer, roughly how many new cases of COVID-19 were diagnosed in the US in the last week, according to the US CDC, so May 23rd to May 29th. So if you can click on the answer that you feel is most appropriate, and then click end poll. Let's see, are we all doing this? Yeah. Glenn, we all doing, you want us all to do this?
Yeah, everyone do it, everyone do it. There's only a handful of us on the call today, but it's beautiful outside, but that's fine. Okay, it looks like the polling is closed. So here are the results. Do you want to read it, Beck?
Okay, so am I reading this correctly? 50% of people believed approximately 10,000 new cases of COVID-19 were diagnosed this past week, and 25% believed approximately 100,000 new cases of COVID-19 were diagnosed this past week in the US. Yes?
And there's one more option.
I don't see it.
If you scroll down, so it says the last option, 25% indicated that they believe that over 140,000 new cases of COVID-19 were diagnosed in the past week in the US. All right, so I'm going to stop sharing that, and I'm going to close this on my screen. I don't know if it's visible on the video, but that's okay, we said it. So most people thought that it was not too much. Let me just jump into this for a second. So if you recall, what started this all? So if you recall, in Wuhan, China, December 10th is when they had their first pneumonia cases that appeared that were a little bit weird because they weren't typical pneumonia. They were showing up a little bit different under radiography. That was December 10th. January 10th, they had 41 positive tests for SARS-CoV-2. January 22nd, they had 571 confirmed cases and 17 deaths. So this was the 6th week, cumulative 571 confirmed cases. That was enough for them to close down, lock down all of Wuhan. And then by January 23rd, so at 2 a.m. is when they made the decision and made the announcement. And then 10 a.m., just a few hours later, a handful of hours later, they had closed everything down. You see that the total cases since then, including then and since then, were approximately 83,500. They've gotten it under control. There's only a tiny number of new ones every day. There was some talk of new outbreaks happening, but they have that under control too, but they're on top of it. And so, I mean, it might still evolve in different ways that we're looking at, not the virus itself, but the way that the outbreak is appearing. We might see changes. But my point here is that 571 were the number that triggered the lockdown in China. In the United States, so now here's the reveal of your answer. In the United States, there were over 140,000 new cases of COVID-19 diagnosed just in the past week alone. And so we're starting to unlock the country in all of these states, and there were over 140,000 new cases of COVID-19 diagnosed in the past week alone. This is not going to be something that testing and tracing will be able to address. There's too many people. So, I mean, that is what it is. And so if it were a smaller number and we had our testing and tracing up to where it needed to be, then we could address it. But there's too many people every day. Right now we're averaging around 20,000 or so, a little bit more. You can see it varies a little bit on a day-by-day basis. But we are unlocking prematurely in many places. In terms of how we're unlocking, I'll just jump into this and then we can open it up to questions. But basically you'll see that there's different kinds of ways of looking at it. So one way is ending the statewide lockdown. That's the biggest constraint that we all had. Currently, only New Jersey, DC, and Puerto Rico, so those territories, are currently still under lockdown. Everyone else appears to be open now to one degree or another, either blue where they're completely, the state is open, or where it's still partial lockdown in the state, depending on the city or towns within the state. You see that in only a few is there a face mask requirement. The majority of states don't even have a face mask requirement when people go out in public. In terms of the status of retail stores, you see that the vast majority are open. Some are curbside only pickup, whereas others are now open for business. And finally, in terms of dining restaurants, you see a fair amount still do not allow in-restaurant dining, but quite a lot do allow in-restaurant, inside the restaurant, dining inside. And so this is going to be problematic. The R value, let me come back to this one. So at time zero, before there were any constraints put on in terms of our travel, in terms of wearing face masks, in terms of testing and tracing, this was just how the virus was behaving in the population based on our normal activity. This R value was strong. We estimate around 2 to 3, but we've definitely identified that there was variation in R by state. Some more densely populated states had higher R values, and some had smaller R values. But this R value, without the face mask, without everything, is what the normal R is for this virus, with the susceptible population. And the vast majority of people in the US are still susceptible. Right now, we're estimating that approximately 4%, a little bit over 4% of the US population has been infected with and has antibodies at this point. So 4% is tiny relative to a herd immunity that we might be talking about at maybe 50% to 80% required for herd immunity. So that's where we are. Okay, Becky, back to you.
Okay, so with that in mind, turn off your volume for a sec. Okay, so with that in mind, what is your best forecast for the COVID-19 epidemic in the US over the summer months?
Yeah, that's a really good question. So there's all of these models out there. And if you recall, one of the first modeling efforts that was done by this group called the Imperial College. They're located in the UK. They're the Imperial College COVID-19 response team. And they did some great work. They were the original forecasters that made the model that indicated that if in this scenario in which there were no lockdowns, in which we continued our behavior as normal, then this number that we see here within the US in terms of the number of infections would have risen until approximately 80% of the population were infected. And based on the best estimate of at the time of the infection fatality ratio, which is different than the case fatality ratio, but the infection fatality ratio among all the people, asymptomatic and asymptomatic, is the infection, whereas cases are just symptomatic. So among all the infected people, the infection fatality ratio is estimated to be approximately 0.9%. And so under that assumption, 0.9% infection fatality rate and 80% of the US population infected, based on the shape of this growth curve, they estimated approximately 2.2 million people would die from the epidemic itself, not including any people who went to the hospital without COVID-19, but that there weren't enough beds, and so they would be turned away. So those people were not included in the 2.2 million estimate. And so they've come out with a new analysis. Thanks to them, we were very lucky. We locked down. We weren't altogether successful. We were obviously much more successful than if the line had continued straight up, but we were not as successful as we would have liked to have been. We would have liked to have come back down to zero or somewhere close to zero. I mean, we're still have a lot of new infections every week. But my point is that they did really high quality work and were able to save a lot of lives. So they've updated their models. And so their newest model relies on a few different things. I think I showed this last week or previous week, but just in case I didn't, one organization was looking at the impact of the reproduction rate just based on summer. And so we see that there is likely to be a seasonal variation, but it's not very much. In order for the COVID-19 epidemic to go away over the summer on its own without any other interventions, just based on the seasonality, just summer coming and the virus getting less, it would need to fall below this 1. 1 is this critical threshold. If it falls below 1, there's less infection. But you see that the variation is only going between around 2.8 and 2.0 or 2.2 in terms of most of this. And so it does have a little bit of an effect, but it's not very large, so it's not going to be very huge. But digging into this a little bit deeper, let me talk to you about the really interesting modeling that this update that the Imperial College has done over the last week or so. And so basically, when you look at I'll show you just at a high level what they've done. So what I'm showing you here is a map. This actually comes from the New York Times, but during the lockdowns, you could evaluate using cell phone data, using cell phone data to indicate travel. That was a good indicator of spread. And you could see state by state, this is actually county by county, where people were still traveling during the lockdown. One of the most interesting things is that even states that locked down, even though they were going down, sometimes adjacent states that hadn't yet locked down, announced formal lockdowns, were also traveling far, far less because they were scared out of their wits. They were reading the news like everyone else. If you're in Pennsylvania and you saw that New Jersey and New York were locked down, guess what? Even if Pennsylvania didn't announce it, you are not going out to eat at the restaurants, you are not going shopping, you are locked down. And so even if there is no formal announcement, that's what we're seeing in a lot of states, that they just dramatically reduced the amount of travel. And that's what we're also seeing in Europe. So for instance, people are looking at Sweden, that Sweden didn't have a strong lockdown that was ever put in place. They did for some groups of people, for instance, university students and for people in over the age of 70, that kind of stuff. But for most people, there was not a formal lockdown. And yet, because they were surrounded by other countries that were terrified and were under lockdown, it influenced the behavior of people in Sweden. So many, many, many people in Sweden behaved as if they were under lockdown, even though there was no formal requirement to be. And so let's come back to the United States for a second. So here we are. When you look at the impact of which counties reduced travel the most, these are the ones on top that reduced it that had stay-at-home orders. The one at the bottom had no stay-at-home orders. But you see that even the ones without stay-at-home orders were still dramatically reducing how much travel they were doing relative to the normal, which was way over here somewhere on the right-hand side. But so the lockdown orders, even on top of that, provided an additional benefit versus just communicating the issue. Just communicating the issue itself, again, reduced the travel, in this case, by what, like something like 2/3, let's say 65%, 66% order of magnitude is the amount that it reduced travel without the formal lockdowns. With the formal lockdowns, it reduced it over 75%. So what are we looking at here? Maybe 85%, let's call it, order of magnitude over here. So they were effective. What this model did, so now I'll jump in. So they created some really interesting results, and that's why I'm bringing it up. I'll just spend a couple more minutes on this part. All right, so I apologize that this is so small, but essentially this is an important one. The dots represent the initial R value. So that's the average number of people who were infected by the initial infected person. So for any infected person, on average, a person in Texas initially was infecting between 2 and 3 people. After the lockdowns were put in place, and so the most recent, we're calling this current. So as of just a couple of weeks ago, in Texas, the R was still above 1. In fact, the R was between 1 and 2. You can look at the other extreme. So some of these, Montana had a very low R to begin with. Their R was lower than 1 to begin with. So a lot of their infections were coming from out of state, and that's why there was still a pool of people coming into the state that were infected. But their R was less than 1. They brought it down even lower, so they're in good shape. Other states like New York, for instance. So New York over here, green. The estimate for New York is that the average R value in New York was actually 5. So every infected person on average infected 5 other people in New York, the state of New York. And one of the reasons for this is a question we might get into a little later if there's interest, but this question of dispersion, super spreaders. And in New York, there seemed to be a little bit more super spreading going on, and it was also a little bit more densely populated. So for instance, specifically in New York City, very densely populated, so it was much easier to infect more people during the infectious period. So 5. And yet New York, because of the lockdown, went from an R value of 5 way down to below 1. That was really good work. The lockdown was supremely effective in New York. You can see the difference here. Went from 5 all the way below 1. That's great. Other countries were successful. Anyone that got it below 1 is doing a great job. The further below 1 they get it, the quicker the infections go away, and there's less infections every day. The closer they are to 1, it's like a steady state. If you had 100 infections last week, or 100 new infections last week, you're probably likely to have around 100 new infections on average going forward in terms of because it's a steady state in terms of the number of new infections. Now, if you are looking over here, you'll see that a lot of states aren't doing well. These states are still growing. They're not an R of 3, but this was under lockdown conditions, or like I said, even if they weren't locked down, they were hunkered down and not going and doing as much as they had been. This was late April, early May. This is what you were seeing, and this was not good. If you look at it a little bit more detailed at a region by region area, you see that some regions were better than others, but across the board, all the regions had a reduction in the R value, and this was largely due to a change in the mobility. People were hunkering down and staying home. And so over here, you can see that because they hunkered down, on average, it reduced the R value, so the number of new people infected per infected person, by almost 75%. So what is this? This is closer to maybe 65, 70% here. And so it was enormously helpful to do that. Let me just show you this picture of the state. So right now here we're showing everything in green has an R below 1. So they were able to manage to get to the R below 1 based on all of these non-pharmaceutical interventions of testing and tracing and staying at home and wearing masks and all these other things we've been talking about. The ones that are in purple, or shades of pink and purple, were doing more poorly, and their R value still supports continuing epidemic. And this was when we were hunkered down. So that's not good shape. Just a few more slides here. So in terms of what does this mean at the population level, you might be wondering what percentage of the US has been infected at this point. And so here's our best estimate. At the national level, around 4%. It's been a little bit, another week or two after this now. So over 4%, but not much more over 4%, roughly order of magnitude 4% of our country has been infected. And so they have antibodies. It varies dramatically by state. So for instance, New York, around 16.6% have been infected. New Jersey, 16.1%. Then you go into some other states like Alaska, Montana, 0.2%, 0.2%, Hawaii, 0.1%. So you see that the range is quite wide. If we're still assuming that the herd immunity won't be reached until around 50% to 80%, It probably might vary state by state and for a variety of reasons. We are nowhere near that. We have a lot longer to go on this. This is just the very beginning of this. Just 2 or 3 more slides here. So basically what they did is they took that information for states that were missing information based on age adjusting, looking at the previous history, looking at transmission data or mobility data based on traveling using the cell phone data and some other things. They were able to estimate based on the nearby states what those states were likely to be. And so based on that, they had low case, which would be stay hunkered down throughout the summer, the way we've been for the last 2 months, which is very, very unlikely. That's blue. Yellow is increased travel, and they use travel as a proxy. So if you go out of your house and then you go to work and whatever, then on average, people are probably letting their guard down a little bit more, and they're not using masks as much as they were, and they're going out and maybe their behavior is a little bit more risky. And at 40% would be a high case, where they're 40% more active than lockdown in terms of going to the beach and going and not wearing masks and just not having their guard down a little bit more. Under those scenarios, it goes a lot. I'll get to this in a second, so I'll keep it here. But they did this at a state by state level, doing this analysis for all 3 cases. One more thing to show you before I tell you what the results are. But basically, so this one, I'm sorry you have to squint at it also. But basically, for each state that we're looking at here, this is the infection fatality rate. So one thing that they realized is because ages differ by state, and there's other risk factors as well, each state is going to have a different infection fatality rate associated with the infection. We've been assuming that there's one infection fatality rate that's global, and we have to understand there's probably not one best number. If one state has a lot of people over the age of 65, and another state has very few people over the age of 65, and we know that people over the age of 65 are at way increased risk, then the fatality rates are going to be very different across the states. And so the key thing to look here, I understand it's hard to squint, but the posterior, this is the best average that we got from the model. And so you can look on average, some states over here, here's a purple one. So this is saying that Vermont, which is an older state, or rather, in addition to being an older state, it has a population that's older in age. The purple is over 0.1%. So that estimate is that it's between 0.1% and it's over 1%. So the estimate is that it's between 1% and 1.1%. So that's a large number. In New York City, as a reference, so with all the people that just died, which was over 20,000 people in New York State died, when you compare that with, I think it was 13 million order of magnitude that we were looking at in New York, if I got that right. No, I think that was a different estimate I was looking at. Sorry, wrong estimate. That was 13 million was the entire US. So let me come back to that in a second. But when you look at the New York in particular, the best estimate was that New York City's infection fatality rate was approximately 0.93%. And that was similar with the average in New York. So when we look over here for New York at purple, 0.9% is this line right here. So that would be consistent with Netherlands. These other colors you're seeing are other reference points, just so you can see where each state would have fell if we were having the same distributions that France had based on age and these other things. So for instance, France, all things being equal, France had a higher infection fatality rate than other countries. Netherlands had a smaller, and UK was somewhere in the middle. And our averages in most cases seem closer to UK, but it varies. It's always right in the middle of these other the experiences in the other countries. Some countries are doing their infection fatality rate seems quite low. So for instance, the best estimate for Utah over here is that it's between 0.6% and 0.7% infection fatality rate. Order of magnitude flu on an average season is 0.1%. So 0.6 to 0.7% is still quite a bit higher, 6 to 7 times as high as average flu, but it's maybe half of what we might be seeing in some of these other states. So I mean, if you look up at this one, at Maine, which is also older. If you had the French estimate for the infection fatality rate, it would be over 1.2%. And so you can see that there's a lot of variation by state. So the final summary, and this brings this portion to the end. And here's the kicker. I'll just read it out loud. We predict, this is the Imperial College team with their most recent model doing all of this intensive modeling exercise that I think right now is the best model that exists out there right now. This is their conclusion. We predict that increased mobility, so increased traveling, which is also correlated with not wearing masks enough and going back to work and interacting with people, they predict that increased mobility following relaxation of social distancing will lead to resurgence of transmission, so increased spread, keeping all else constant. We predict that deaths over the next 2-month period, so by August, could exceed current cumulative deaths by greater than 2-fold if the relationship between mobility and transmission remains unchanged. So unless there is significant increase in contact tracing, rapid testing, and more precautions than we're seeing, they're predicting that if there are over 100,000 deaths already at this point, a few weeks ago, we probably passed that 100,000 point of number of people that died from COVID-19, then their model is predicting that we'll probably get another 200,000 deaths by the end of August or before the end of August. So this is—
Did I hear you right?
Yes.
So
this is disheartening.
total of 300,000 in the US?
Right. And so this is consistent. Remember, these are the folks who originally estimated 2.2 million if we didn't do the lockdowns and did nothing. And so we were able to flatten the curve to a degree and to push it into the future, because the goal was to push these infections into the future so that we could work on vaccines and work on new treatments and work on contact tracing and testing to really get it under control so we could stop the spread. And that was the whole point: push this infection and the epidemic into the future. And that would be the way to save lives. The problem is that now by reopening, it's reopening. And so there's going to be more spread, given just using the simple model that they've done based on the relationship that's already existing between how contagious the virus is in the counties by who's traveling the most, based on this existing relationship of spread over the last 2 to 3 months. If that relationship stays roughly the same and there's no change, there's no dramatic increase in contact tracing, no dramatic increase in testing, et cetera, then that assumption will hold. If we immediately start increasing contact tracing and testing and widespread testing and making sure that everyone wears masks and really enforce additional requirements, then we will not hit that number. But otherwise, based on this that I've showed you just a little bit earlier, based on this, our goal, one last thing here. So our goal in flattening this curve with the lockdown was to reset the clock. We knew that this was getting out of control. We were trying to get it down to 0, and then contact tracing and testing would be so much easier, and we'd reset the clock. The problem is we've reset the clock, but our new floor is giving us 140,000 new cases a day. So this is our new floor now. So we're going to probably be going up from here. So people have been talking about a second new wave, but we're still in the first wave. We never got through this one. And so now this is our floor. So everything going forward is going to be from this floor. So we have to hang on to our hats. It's going to be a wild summer.
Glenn, can I ask a question?
Please.
Sorry, do you hear the echo? No, it's good now. So if 140,000 people are being, sorry, let me get this right. We're seeing 140,000 new cases a day, right?
No, a week. So roughly 20,000 a day, 140,000 this past week.
Okay, so that's just of people being tested. One of the kids asked me this morning, well, why would somebody bother getting tested if there's no treatment? So so how many people do we think are actually really being infected every week?
Yeah, that is a really good question. All right, so this, you're right, are people who were diagnosed. And so there are probably people who have symptoms and are not diagnosed, and there are people who are asymptomatic and not being tested. This is a question of the test positivity rate, and I don't know that I have a good recent one, a good recent slide for that. Let me jump. I do have a previous slide. I should have updated it this week, but this is the test positivity rate. We are in way better shape. This is from May 13th. We're way better shape. Ultimately, we need to get the test positivity rate down below 5%. Testing availability is far more widespread now than it was a few weeks ago. And so the tests are way more easily accessible and free and easy to get right now. So a lot of people who have symptoms are now being requested, especially now that we're opening up, are being requested to go and get tested. There are two important reasons there are two important reasons to get tested right now, even though there's no treatment. The first is if someone gets sick and they realize that it's COVID-19, they need to quarantine themselves in place, not touch anyone else, not go near anyone else, not infect their family members even, stay in their own room for 2 weeks and have minimal contact even within the same house. But certainly don't go out. Those people, this isn't a lockdown for people under quarantine. For people under quarantine, they can't go out to the supermarket. They can't go out for the walk around the street, the block. These people need to be quarantined so they don't infect anyone else. So that's the first thing. And also by doing that, then they can look at the additional symptoms, because some portion of those people are still going to become critically ill. So those people will need active monitoring. They'll need to be testing their temperature frequently. They can't just relax at home. They need to be ensuring that they're okay. And at the first sign that they maybe should have escalate their treatment because they're really starting to not be able to breathe well or having other more advanced symptoms, they need to immediately go to urgent care or talk to their physician about going to urgent care or to the doctor with the proper precautions with masks and everything else. That's the first thing. The second thing, which in some way is more important, is they don't want to infect anyone else. We can't look at this as individuals being infected. All of these people are in chains of infections, and we need to stop the chains of infections. No kid wants to be responsible for killing their grandmother. And if they get sick and they infect their grandmother, then that grandmother is at extremely high risk of dying. And similarly, the neighbor, you don't want to put your neighbor at risk of killing them. You wouldn't want to go to the supermarket and put them at risk of dying. Maybe the ones going out to the supermarket are not the 70-year-olds. Maybe it's a 30-year-old who lives with the 70-year-old. And so these chains of infection could kill all these people along that whole chain of people you might infect if you go out in the world. So that's the second most important reason that's probably even more important than the first, because most people who get it will not have severe symptoms or die. Only around 0.5%, as you saw in the figure before, 0.5% to 1.1% maybe order of magnitude of the people who get infected will die, but the vast majority will not. The most important reason, therefore, is probably that we don't infect others. We need to stop this chain of infection.
Thank you.
There's also one more thing. There are a lot of people who are getting severe symptoms. They too are still a minority of the total infected population, but there are some severe symptoms that people are going to have for quite a long time. So for instance, some people have survived, but have severe lung damage. And so they're going to have scarring in the lung tissue, and that's going to be with them for a long time. Other parts of the body, there's other organs that have been involved from COVID-19, that's going to stay with them. People have had produced blood clots, and some of them have had heart attacks and strokes. That's once you've had that, it changes your body. There's structural changes in your body, and that doesn't go away. And so a lot of these people are going to have long-term consequences to this, even if they survived among these severe cases. And so we have to understand that the risk to our population is high. The risk to ourselves, if I'm a 10-year-old, the risk to myself is very low. My biggest risk is I have to make sure I stop the chain of infection and prevent other people from having serious illness and dying.
Thank you, Glenn. Oh, turn off your. Okay. Still have the echo.
How about you mute all? Oh, that's
Okay.
not going to help.
Sorry about that.
Okay, that's okay.
You mentioned super spreaders before. Since we were last together, a lot has changed. Being number one, a lot of people were together for Memorial Day activities, and number two, of course, the riots that are happening across the country. What role do the super spreaders play in these activities?
Yeah, that's a really good question, and I hope I can find it fast. All right, so here are, so you, at this point, everyone's heard of the R value, which is so great. As an epidemiologist, virtually no one, maybe some people in medical school knew what the R value was, but even in medical school, probably a lot of people, a lot of physicians out there didn't really know very much what the R value meant because they might have only taken one epidemiology class in medical school. So this was something that a lot of people just didn't know what it was. I think now most people in the United States and abroad know how we interpret R. But with diseases, there's another factor that a lot of people haven't talked about. So I'll introduce it here to people. And it's called this dispersion factor, K. And the dispersion factor tells us about super spreaders. And so, it tells us about, like, so for instance, how many disease clusters there are. Is there one person on average that's infecting one person, or is there one person that's infecting 100 people, and then a lot of people infect no people? And so, what is it? Mostly super spreaders, or mostly much more wide distribution in terms of the dispersion of the spread? And the lower the K is, the more super spreaders there are. So again, the lower the K, the more transmission comes from a small number of people. So here are some examples. So SARS, which was the first one, we're in SARS-CoV-2. SARS-1, which happened almost 20 years ago, had a K of 0.16. In contrast, MERS, the Middle Eastern Respiratory Syndrome, had a K of around 0.25. So that meant that MERS was spread by more people spreading it, whereas SARS had more super spreaders involved. The flu pandemic of 1918, as another reference point, the K was about 1. So that means that there were far less super spreaders or clusters. It was more evenly distributed, so any individual was likely to infect any other individual with roughly the same likelihood. Whereas when you have a smaller number, some individuals are super spreaders and might infect dozens of people, whereas others might infect nobody at all. The R value, again, is the average across all the population, the number of people that a single infected person will infect across, on average, across everyone. So if you have an R of 2, then on average, you would have 2 additional infections from one initial infection. But with K, it could actually be that you have a super spreader that spreads it to 100 people, and then you have a lot of other people who spread it to no one. And then the average of all that would still be R equals 2. So this dispersion is really interesting, this question of super spreading. Here's how a lot of other outbreaks have compared. So SARS tended to have more super spreaders. Oh no, actually it goes the opposite. This is a little bit different. So this is a little bit different. I think I might have used these from 2 different sources. But so let's use the one on the graph from this one. This is the proportion of cases due to the most infectious cases. Oh no, here's the dispersion parameter. So the closer you come up here, the more super spreaders there are. So the closer you get to 0, the more super spreaders. The closer you get on this side to the right, the fewer super spreaders that we have here. All right, so SARS had a lot of super spreaders, and you see this so that you can see over 80% of the people who were infected during SARS-1, over 80% of them were infected by a super spreader. Whereas something like here, the pneumonic plague, less than 50% of the people were infected by a super spreader. So this makes a big difference. You see that this has a big difference. It seems like it varies by location. So for instance, population density makes a big difference in terms of how likely other people are to get infected. And so super spreaders in a city, it's easier to infect quite a lot of people, whereas a super spreader who lives on a farm is not going to be likely to infect a lot of people. So one more slide here. And so in terms of looking at the dispersion factor for COVID-19, There have been some estimates looking at it. And so right now we believe that the estimate for K, so for this dispersion factor for COVID-19 varies between 0.1 to well over that. And so the estimate is around 80% of infections are spread by 10% of the people, would be on the low side, to more something like a more widespread spread of the disease. And again, this probably varies based on population density and other types of things as well. But you see that there's still uncertainty about this, and it's something that's currently being investigated. All right, that's enough for that. All right, Becky, you're on mute.
Thank you for clarifying super spreaders. So how are we doing, Glenn? How are we doing compared to the rest of the world? This is not looking so good from my vantage point. How about from your vantage point?
Yeah, so
are we making improvements, and what can we learn from others, or what are they learning from us?
Yeah, that is a good question. So let me see. That's not what I want. I want this one. Can you see my screen? Yes, because I can see my screen. All right, so let's scroll down. First, I'm going to show you. Remember, we were talking about that magic number, the number of new diagnosed cases of COVID-19 this past week. So again, this was total diagnosed cases of COVID-19 this past week was 140,000. So there's a lot of countries that are doing really well. So for instance, Australia doing really well. They had 10 new cases on average over the last day. And so that was 70 over the new week. So Australia had 70 relative to our 140,000. We're a bigger country, but if you were to adjust it, theirs would still be quite smaller. You can see that they got their curve up. They peaked because of the lockdown and very rigorous follow-up with patients and testing and tracing and all of that. They were successful at getting their numbers down. Similarly, when you look across a lot of other, whoops. All right, let me put this over here. All right, so similarly, when you look across a lot of other countries, you'll recognize a lot of countries doing really well. So here's China, where it all began. Although we're actually not 100% certain that it did start in China right now. It's very, very, very likely that it did, but there were some early cases that we are seeing now in some other countries. And so the early evolution of how it spread in the global population is still something that we're trying to figure out. But it's still extremely likely that China was the first, because otherwise we would have seen more increased hospitalization rates in other countries more quickly. All right, but when you look at some other countries, so we have relatives in Estonia, and so you see that they're doing really well. They had 7 cases on average over the last day, so they're doing well. Then you start getting into Europe. So here's Iceland, but here's some other countries that you recognize, like Israel had 14 cases in the most recent day, Jordan 13, but then you start getting to Europe. So Eastern European countries, and into looking at that area of the world over there, you start getting into, they're doing extremely well, 11 cases, 8 cases. You start seeing Norway, South Korea, remember how they were so close to China, and they had this, they were doing well, then they had a peak, but then they got it back under control. They're doing 20 cases a day. All right, so Taiwan, a lot of countries doing really well. Now let's look at some other parts of Europe. They're still working. France, they had the peak. They've been working really hard. They're at 340 cases a day or so, but they've gotten it really low. So that compares again to our 140,000. Again, US is quite a lot larger, but you can just see what their peak looks like. They got it way down. They still have a little bit more to go, but they got theirs way down. Similarly, Germany, look at how great they're doing. They were going up. The R value was very similar in all our countries to start, but then because of our interventions, we got it way down in most of the world. And you see they're doing 600 new diagnosed cases a day compared to our 140,000. And so they're doing well. If you look at some others, I mean, so you look at Hungary and Ireland and Italy. Italy, you remember how poor they were doing. They were had so many deaths. They were one of the first lockdowns after China. And you see how well they've gotten theirs under control. And now they're down to approximately 650 every day in the most recent days. And they're still going in the good direction. You see a lot of countries like that. Switzerland, look at these countries are all almost there and getting it under control. We're not talking a lot. When you have 170 new cases a day, that's something that you can manage with testing and tracing and really getting it under control. So you can open it up a little bit, but testing and tracing itself can get things under control so that they can stop the spread. Now you get into countries that are in trouble. And I say this because right now, it is the fall and approaching the winter in the Southern Hemisphere. And what happens in the Southern Hemisphere is what will happen to us in the Northern Hemisphere in the winter. And you can see they were under lockdown for a little while. It was good for keeping it that the peaks didn't get too high, but they got exhausted from the lockdown the same way that we did. They were still under lockdown. Technically, the policy said, stay under lockdown. But look at this curve. It's going straight up now in Argentina. They are in trouble. They're currently under, the most recent day had 500 new cases in a day. But we know based on this curve, it's an exponential curve. There's no sign at all that it's at a peak or going to come down. This is just based on everything you can tell, there's no immediate interventions that are about to happen. This is just going to climb exponentially for a while. Similarly, you look at other countries. Let's jump to Brazil, a large country. They're at 16,000 a day. Again, it compares to our 140,000 a week. I'm sorry if I just a little while ago said 140,000 a day. 140,000 in the last week, roughly 20,000 a day. But Brazil, you see also, this is going virtually straight up. They had a little hiccups to try to get it down. Nope, continuing to go straight up. They are in trouble. Once you get to this number of people, it is extremely hard to do contact tracing and have enough tests to get it under control. And so it's going to be really hard to get this. They were under lockdown. Brazil was under lockdown, and over the last week or so, they just said, we can't do it anymore. And they're just going out. I think even the policy itself is now deteriorating a little bit because the country, it's been months and they couldn't hold it anymore. And so here it is. There's nothing that's going to stop it now. They're in their winter. And so here you go. They're in a rough ride. This is going to be us in our fall and our winter. It's really hard. The normal R value is 2 to 3 that we found. Again, it varies by state that we were looking at that I showed you a little bit earlier, but it's just going to continue going way up. And this is the same across lots of countries. Colombia, Chile, either other parts of the world, you see these countries that are struggling. Then you come to, Iran was struggling at first, managed to get it under control. Then they removed the lockdown and see their R going right back up as if it was right at the very beginning again. And so that is likely what we're going to see in the United States. Here's Mexico. So Mexico was under lockdown for a while. They weren't doing so poorly, but then people get exhausted and they go out, and this is what you get. And so they're starting to go straight up as well. Next, so we'll keep on coming. Then we come to, just in case you're curious, here's Sweden. So their approach, they're not zero there. They don't have a lot of new cases every day. It's a lot more cases than you would expect based on the size of their country. But their R is around 1 on average. If you look at it, just noise around 1. It just keeps on going up and down and up and down and up and down. And so just staying pretty flat relative to the long term. And so they're keeping the number of cases and deaths at a pretty constant rate each week, although this is reported at a daily level. So now we come to the United States. And here we are, a little bit over 20,000 a day on average. It goes up and down a little bit, but this is our new floor. And you can see this is the summer, should be our easy time based on the R going down a little bit. But when fall comes, we're talking September, October, November, when normal flu season would start to hit, this is going to be very problematic. All right. Beck, you're back on mute, I think.
Okay.
Are you?
Oh.
Okay, we can hear
Okay.
you now.
So we have a great question that came in from Jill Marcus about what's going on in the hospitals, the hospitalization rate versus the number of cases, so that our testing ability has increased. And so now we know that we're seeing more cases, but has the hospitalization rate remained the same? How has that compared?
Yeah, that is a really good question. And whoops, there. All right, so so I think I mentioned this in a previous week. This is based on the best estimates that the federal government have put out by this, I think it was the CDC, but the federal government put out these best criteria that in order to reopen, we should meet the decreases in disease spreading so that it was under control and we could have contact tracing and testing, that hospitals should be able to handle the load, which is the question that was just asked, and then make sure that testing is enough. Based on the map that's tracking it, green means that they're trending better and are on target to reopen. Yellow is making progress to reopening, and red is trending poorly. You can see from what I showed you a little bit earlier today that a lot of states are now opening wide open, or to a much larger degree than we were, but you see that there's a lot of states that are not ready to reopen according to that. In terms of hospitalization, I like this website because it tracks all that stuff. I think the second table down, this is spreading. This is key measures. Let me come down. How can our healthcare system handle the spread? And so this is the intensive care unit availability. This is the bed availability, and this is the new cases per million per day, and the case fatality rate. Again, the difference between the infection fatality rate and the case fatality rate are the cases are the diagnosed infections, whereas the infection fatality rate includes everything. So includes people who are asymptomatic, the people who have symptoms but don't go to the doctor, and the ones who are diagnosed. And so you see that in some of these, a lot of people are not going and getting diagnosed. Connecticut still, a lot are not. But in terms of the bed availability, you can see that some of them are doing quite well. Some of them are still have low availability relative to what you'd expect. Maryland is really not doing well. They still do have capacity, but their capacity is not nearly as high as some others. And so there's a difference between the intensive care unit versus the beds. A lot of people with COVID-19 need to stay in the hospital for more than just a few days. And so you need to look at beds and not just intensive care unit. But so you're looking at DC. DC, for instance, as an example, has poor capacity in the intensive care units, but has a little bit better capacity in bed availability. And so you can just scroll down. I'll scroll down a little bit more slowly. Some are doing better. You see a lot of green over here where the capacity is great. And you see some over here, Rhode Island, low capacity in both the intensive care unit and the beds. I'll just scroll down a little bit more, but yeah. So you see that there's high variation across the country. Okay, back to next question.
Okay, put it on. Okay, so we're talking about testing and tracing, and it sounds like it's working well in some areas. Has it been successful with other infectious diseases like HIV? Are we learning a lot from those types of diseases?
That's a really good point. So we know best practices from these other diseases, from HIV, from syphilis, from other infectious diseases. We know best practices for testing and tracing. But it's always been a challenge for a variety of reasons, not just the logistical reasons, but even more, it's very intrusive and very invasive. And there's a lot of reasons people don't want to be tested, and a lot of reasons people don't want to be traced. So for instance, if people are engaging in illicit behaviors, say illicit substance abuse, or other kinds of things that they're involved with, or criminal activity, if they don't want to self-identify that they might be exposed to police or other people who might turn them in for something, and they don't want to be found. Maybe people who are here illegal as undocumented immigrants. They might not want to be identified. And so you have a fair number of people who would probably push back. Also, there might be political motivation for one reason or another. Maybe people who are anti-vaccine might not like having someone who they don't know coming over and testing them against their will. There's a lot of reasons. So it's logistically hard, and there's reasons people might not be interested. But so for HIV as an example, and I had a chart here. So what we're looking at here are the number of people living with HIV. So HIV over the years, with these effective treatments that have become available, is now essentially a chronic disease for people who have HIV. It's people who have HIV on average have the same life expectancy as people who don't have HIV, because these meds are so effective that it tends to be a chronic disease. However, there's still contact tracing that's going on with the testing. And what we're finding is that down here, the number of dark blue are the number of new HIV infections that are going on in the United States every year. And you see that there continues to be quite a lot. We're not talking about, these are the number of people in millions. Up here it's 5 million. So it's under 5 million, but over 1 million. It looks like we're talking about, so quite a lot of people newly infected with HIV. But this was back in 2008. It was still decreasing over time. So now we're 220. So it's a bunch of years later. But it's hard to do. It's hard. So it's going to be a real struggle. It's always been a challenge for public health to do the kinds of work necessary to help save lives using contact tracing and other public health interventions. Now there's more attention being paid to COVID-19, but I worry based on what we're seeing over the last week that this might be a challenge. All right, Becky, I think that we're running out of time. Do you want one more question, or should I talk about the geography question?
One more question, and then I don't want to hear any more bad news. Can we talk about puppies?
All right, I'll talk about
one more question. So Jill asks, what percentage of people diagnosed with COVID will likely require hospitalization? So as our numbers of infections increase, what are we looking at as at the percentage of those folks who will end up in the hospital?
Yeah, that is a really good question, and I don't know the answer offhand, so I'm gonna have to get back to you for next week. What I do know is that our early estimates of the infection fatality rate, not the case fatality rate, so the diagnosed case fatality rate, but the infection fatality rate was around 0.9%. And it varied a little bit, but that was our best estimate even a couple of months ago. And now that we've had a lot of experience with this disease in the United States, we know that it's approximately 0.5% to 1 or 1.1% infection fatality ratio. That a quantity of severe illness, the people that die, every single one of them was severely ill before they died. So the asymptomatic people are not the ones who die, except, so technically, when people are first infected, then they go through an incubation period. And so everyone who's eventually symptomatic will go through an asymptomatic phase. But typically when we're talking about asymptomatic people who are asymptomatic throughout the duration of their infection, none of those people will ultimately go on to die. It's the ones who are the severely ill people that have the complications that require going to the intensive care unit that will then go on to die. I'm not sure where that's ending up right now. I have heard that earlier diagnosis can help keep people alive and safe. So for instance, if people identify that their oxygen is lower than they thought that it should be because they have a pulse oximeter at home, then if they identify that to their physician, they can go to the hospital earlier, get oxygen supplementation earlier, not intubation, not ventilation, but just have oxygen earlier. That itself, without anything else, can help prolong their lives and can help prevent their deaths. And so that makes a huge difference. But in terms of the severity of the disease, I'm gonna have to get back to you on that. I'm assuming that the rates now are not so far different than they were, let's say a month or two ago, in terms of the ratio of the ones who die versus the ones who are severely ill. That's probably the similar ratio between those proportions are probably similar. But now, so let me get to your other, to your other two questions. Okay, so
we look forward get an answer from you next week.
Okay.
And,
Okay, but first I'll answer the puppy question.
but wait, sorry, I didn't hear. What did you say?
Okay, I can answer the dog question if you want. So here's good news.
Oh,
So
terrific.
there are dogs that are being trained to sniff out COVID-19. Dogs, as you may know, have very sensitive noses, and they have been successfully trained to diagnose other types of diseases. So dogs have already been trained to detect cancers, malaria, Parkinson's disease, and other diseases just by smelling it. And they are being, right now, going through clinical trials to see if we can train them to sniff out COVID-19. Because wouldn't that be great if we could train dogs, have them at airports, have them at other public places where we wouldn't even have to test the people just with the thermometer alone. We could just have the dog sniffing around and testing for us to see if there's any virus that's being transmitted. This would be great. It's a happy puppy story, and so why don't we end it with that?
Maddie says thank you.
You're welcome, Maddie.
Wait, hold on. I didn't hear you. Hold on one second. Okay.
I said you're welcome.
All right. Well, we thank, on behalf of the entire audience, both live and later on YouTube, we thank you for hosting today's session. And is it fair to assume that we can reconvene next Sunday, same time, same place?
Yeah, sounds good. It's summer, and so everyone's doing stuff, including me, during summer hours. I think next week, let's do it again at 3. But as summer progresses, maybe we'll do it later in the day, like 7, 8, 9 o'clock or something. We'll have to see what people want next week. But next week, 3 o'clock.
Sounds good.
Great.
Glad everybody stay safe, be well, and wash your hands.
Have a great week, everyone. Take care. Bye-bye.